Melatonin is a multifunctional hormone, and it exhibits a variety of beneficial effects in the gastrointestinal disorders, independent of its most widely known effect on sleep. Animal studies suggest the production of melatonin in the GI tract by the enteroendocrine cells far exceeds the pineal production of melatonin. The melatonin receptors in the gut have been shown to play a role in motility, inflammation, and pain. Melatonin has also been shown to influence the gut microbiota composition, reducing dysbiosis induced by stress and sleep deprivation in an animal study. In one study, people with IBS and sleep disturbances had 3 milligrams of melatonin taken before bed for 2 weeks, and it significantly decreased abdominal pain and rectal sensitivity. These findings were supported by another double-blind, placebo-controlled crossover study where 3 milligrams of melatonin reduced abdominal pain and bloating in women with IBS. In postmenopausal women, daily supplementation with melatonin at a dose of 3 milligrams in the morning and 5 milligrams in the evening for a period of 6 months significantly improved the overall symptoms at 4 and 6 months compared with the placebo in those with constipation-predominant IBS. In a small study that examined a wider array of symptoms, besides the improved bowel function, melatonin was associated with a 43% improvement in overall quality of life compared with a 14% in the placebo group. Overall, the IBS scores improved by 45% among those who were taking melatonin compared with 16% in those who were taking the placebo. Some evidence suggests that vitamin D supplements can benefit people with IBS, particularly those with a vitamin D deficiency. In one study that randomized 88 people who satisfied the Rome-4 criteria for IBS and who had a vitamin D deficiency or insufficiency, the subjects received either 1,250 micrograms, which is 50,000 international units, of vitamin D3, or placebo weekly for 9 weeks. All participants also received 135 milligrams of the antispasmodic drug Colifac twice daily. Among the 74 subjects who completed the study, the IBS symptom severity and the level of inflammatory mediator interleukin-6 decreased significantly in the vitamin D group compared to the placebo group. Another randomized control trial found 50,000 international units of vitamin D3 every 2 weeks improved some of the biomarkers related to the inflammation and oxidative stress relative to the placebo. The effect on certain inflammatory biomarkers, TNF-alpha and interleukin-17, was evident only in the subjects with IBS-D, but changes in other inflammatory markers and in those related to oxidative stress were apparent regardless of the IBS subtype. In a 6-month randomized control trial, 90 participants with IBS took either 50,000 international units of vitamin D or placebo every 2 weeks. The subjects who received the vitamin D reported improved symptoms compared to those who received the placebo. A trial that enrolled 112 adolescents with IBS and low vitamin D levels found supplementation with 2,000 international units daily for 6 months improved the symptoms compared to placebo. On the other hand, a trial had 135 participants with IBS and low vitamin D levels take 3,000 international units of vitamin D or placebo every day for 3 months, and it found no difference in the symptom severity at the end of the study, despite a significant increase in the serum vitamin D levels. Although not all studies have found a benefit with vitamin D, supplementation is reasonable for those with IBS, given the minimal cost and the robust safety record to vitamin D. There's a multitude of mechanisms by which berberine, the yellow-orange alkaloid that's found in botanicals like Oregon grape and golden seal, can be useful in the setting of IBS. Berberine has well-documented antimicrobial effects, and it supports the integrity of the intestinal epithelial tight junctions. In animals, it's also been demonstrated to have anti-nociceptive effects, reducing visceral hypersensitivity. Berberine has been shown to be effective in human studies for the treatment of diarrhea of various etiologies. In patients with IBS-D, the treatment with 400 mg of berberine hydrochloride twice a day for 8 weeks significantly reduced the frequency of the diarrhea, abdominal pain, and the urgent need for defecation compared to placebo. Improvements were also seen in scores of IBS symptoms, IBS quality of life, and depression and anxiety versus placebo. A retrospective study of a combination that included berberine, guar gum, and melatonin found the treatment was associated with significant improvements in functional diarrhea, or IBS-D. At 30 days, diarrhea events were reduced by 50 to 70%, and by 90 days they were reduced by 70 to 80%, with more than half of the subjects reporting normalized Bristol stool scale scores. Berberine in its sulfate form has also been shown to be effective for acutely improving diarrhea due to enterotoxigenic E. coli. A recent systematic review and meta-analysis out of China, a region where berberine is widely used as a treatment, surveyed 38 randomized control trials where berberine was used as a treatment of diarrhea of various origins, including infectious and non-infectious causes. Typically, the berberine was given for a short period, similar in time to a standard course of antibiotics. Various other interventions were allowed in the study, and they included antibiotics, probiotics, B vitamins, and clay. Overall, it was found the berberine improved the clinical outcomes and it shortened the duration of diarrhea compared to the control interventions, with no serious adverse events reported. Although berberine has been studied and it's shown to have a high level of safety in human clinical trials, concerns about its long-term use have been raised on the basis of preclinical studies that suggest the long-term berberine use, especially at high doses, may impair cellular metabolism in specific types of cells. The implication of this preclinical research is yet to be determined by long-term human clinical trials. However, short-term use of berberine would be recommended. Glutamine is the most abundant amino acid in the body, and it's an important fuel for the intestinal epithelial cells. Glutamine is considered a non-essential amino acid due to endogenous synthesis. However, in hypercatabolic states, such as severe burn wounds, infections and surgery, and possibly also pregnancy and substantial growth periods, it's often considered to be conditionally essential. In periods of high physical stress, such as these, the rate of glutamine consumption by the small intestinal mucosa exceeds the rate of production, and in these cases, glutamine has been shown to improve intestinal permeability. Glutamine has been shown to be of clinical benefit in settings where intestinal repair is important, such as Crohn's disease and post-infectious diarrhea. In individuals with IBS-D, subsequent to enteric infection, a randomized control trial found that glutamine at a dose of 5 grams 3 times a day for 8 weeks improved the IBS severity scores meaningfully in almost 80% of individuals, compared with only 5% of the placebo group. Those in the glutamine group also saw highly significant improvements in daily bowel movement frequency, Bristol stool scale score, and intestinal permeability. Intestinal permeability was normalized in the glutamine group, but not in the control group. Exercise, particularly at intense levels or in hot temperatures, has been shown to increase intestinal permeability. In fact, 25 to 50% of elite athletes are troubled by gastrointestinal symptoms. Extreme temperatures and inadequate hydration further contribute to dysregulated gastrointestinal function. Glutamine has been shown in multiple clinical studies of athletes to help to reduce or even prevent the increased intestinal permeability that's related to the intense exercise. According to a 2012 national survey, the use of digestive enzyme supplements by individuals with IBS is common. A comprehensive enzyme supplement commonly includes lactase for the breakdown of lactose, enzymes like xalanase, cellulase, and hemicellulase for the breakdown of plant substances, specific enzymes to facilitate the breakdown of gliadin, proteases to support the digestion of protein, lipase to improve the digestion of fat, and alpha-galactosidase to help to break down oligosaccharides found in foods like beans. Supplementation with specific digestive enzymes is well recognized as an intervention for the treatment of digestive symptoms associated with lactose intolerance. Supplemental enzyme ingestion is also used as an intervention for the symptoms associated with exocrine pancreatic insufficiency, and this has symptoms similar to IBS, particularly in its mild state. As the exocrine pancreatic insufficiency is typically diagnosed when the pancreatic lipase falls below 10% of the normal pancreatic output, many individuals can experience symptoms related to inadequate pancreatic output before the diagnostic threshold is reached. Several diseases have been linked to exocrine pancreatic insufficiency. Reduced pancreatic elastase production was identified in about 40% of the individuals with long-standing diabetes, while celiac disease and alcohol use are other potential contributing factors. A comprehensive stool panel that includes the assessment of digestive health measures, and it assesses for undigested fat, can help to determine if mild exocrine pancreatic insufficiency is a contributing factor to mealtime symptoms that are attributed to IBS. As there might be a mild exocrine pancreatic insufficiency, undiagnosed food intolerances or sensitivities to high FODMAP foods, the use of digestive enzymes as a dietary supplement might help to improve the mealtime-related symptoms of IBS. For more on IBS, herbs, supplements, and natural treatment plans, check out my website.